Georgia. This is an awesome place. It's almost 6 o'clock. Sun is still shining, and we have some people from Columbus in this place. The name of this town is Columbus. The place called Salt Cellar. It's an antique place, and we just love it. So from here, we're going to talk about the story about Doctors ACO. So I'm here to represent Doctors ACO. I'm one of the members of the Doctors ACO. Doctors ACO is a group of independent physicians who has repeatedly, one time again and again, shown that we are high quality, low cost physician, and we save money in 2019, and we are showing sign that we're going to save money in 2020. So tonight you're going to hear what Doctors ACO do for the physicians. We're going to show you the tools, what makes a difference in making a high quality physician. And we're going to show you these tools, how they stop the waste in healthcare. Our ACO started in 2016 and has been successful. Looking forward the next 5 years of continuous success. We are risk ACO. That means if we don't do good, we have possibility of losing money. So we are so confident in our process that we will get you to right path if you join Doctors ACO. In my mind, all independent physicians really need to examine throughout this United States. That's why we made this meeting a national meeting. So please listen. If you are an independent physician, and if you know some independent physician who not in ACO, please talk to them about joining ACO. And if you are in ACO and ACO not doing your service the way it should be doing, then you should rethink your decision to join Doctors ACO. So what will happen after being a high quality and low cost physician? The process will start again to a next level. Next level, we are thinking that physician will take their destiny in their hand and develop a Medicare Advantage plan and later on insurance. Just imagine physician owning the health insurance plan. Then you almost control your destiny in your hand. So David, come on down and tell us what Doctors ACO do for independent physicians, and if they join us, how can we help them?
Thank you, Dr. Agarwal.
Tell us about you, David.
Okay. So I'm David Klabonis. I've been working in the ACO business since 2012, believe it or not. So I've been doing this for 9 years. And I get the chance to work with the highest quality independent physicians in Georgia, Ohio, Indiana, and I'm here today in Columbus, Georgia. Just some brief housekeeping. So please pay attention here to this slide. Thank you for the overview from our distinguished chairman, Dr. Subodh Agarwal. And then for those of you that are attending nationally, what we're going to talk about is some Doctors ACO specific projects, and you get to see what it's like to work with a high quality independent physician ACO. And hopefully you can take this back. You can start your own ACO. You can join Doctors ACO, or darn it, you can ask your ACO to perform just as well as us. So Doctors ACO is growing. And just the last month, we've hired 3 new employees. So, you know, with COVID, we've been seeing you less in person, but that's going to change as things are updated. But you have the cell phone numbers of local contacts here in Columbus. Rochelle Gordon is your contact, as well as the contact information for all of your leadership. So please take a note of this slide, and please call you if you have any ACO concerns whatsoever. But Doctors ACO is growing, and you'll see why here in a second. Doctors ACO pays for your engagement. So thank you to the physicians who are here locally, and thank you to the Doctors ACO physicians that are attending by Zoom. So your attendance is very much encouraged, and we pay for your time. Please also ask your staff and your physician extenders to come to these meetings, because they do a lot of the work that makes you successful. So there is compensation to attend. Doctors ACO is doing amazing. We've been waiting a long time for the current contract, and it's not about if we're going to have shared savings, it's how much. And if we do just conservative projections with this independent physician contract that's as under risk as Dr. Agarwal presented, the ACO is projected to get $6 million in 2020. It's going to go up 25% with conservative projections to $8 million. And by the time we get the 2024 savings, the ACO is projected to receive $14 million. So I don't want you to have regret. So if you put forth effort in the ACO, I can assure you there'll be money there. But my concern is there'll be physicians in your community that do put forth that effort, and they're going to have some significant payments. So, you know, the pay is coming. If you put forth the effort and make sure your numbers are good, you will be compensated. We have a very simple plan, and we've come up with some really great tools of late. So in order to get to the 10, 12, $14 million in shared savings, we ask that you work the Care Tracker tool. Just 35 patients a week. It increases your practice revenue. You see your patients more often and medically necessary, and it reduces costs. The second thing is work the SuperDoc app. You get all the alerts for the hospitals that participate, which includes Piedmont. So you're able to do care coordination for your patients at admission, but most importantly, you can know about discharge and you can schedule the TCM. The TCM pays $230. Don't miss out on this opportunity, but every single alert that you get on your phone, please coordinate care, please do the TCM. And then you'll hear more about the third part of the project. We're still building this here in Columbus, Georgia, but we have an outreach home visit program for those patients that are not able to be managed in the office. You can see them at home with one of the high quality mobile physicians. We need to find out who that's going to be here locally, but that's a great solution for patients that our PCPs find very hard to manage in the office. So you have an ACO. You may think, hey, I didn't know the ACO was so big, but the physicians in this room and Doctors ACO, you are responsible for $121 million of Medicare expense. You are the CEOs of this much expense for Medicare. And if you're able to reduce cost just 5 or 10%, you can see how the numbers add up and you can see how the incentives are there for you. The ACO started in 2015. You're in Georgia, Ohio, and Indiana. You have 11,600 patients. A very important number you need to keep in mind is that you need to save 2% or the ACO doesn't receive payment. So you'll see that number as we're working towards the year, quarter one, quarter two. You got to make sure you beat that threshold. And you've been able to network. You have 50 practices with 111 physicians. And if you're able to recruit more, that only helps you. So as these payments keep on coming in, as you have success in your office, please spread the word because you only get stronger as you add more independent physicians. Tonight is a night for celebration. We have Q4 numbers. These are not final. These are not absolutely final, but they're not expected to change much. And right now, the ACO, as you saw on the other slide, is expected to be paid $6 million, and you will receive your checks by Halloween of this year. So we're going to have a very great celebration. You're going to receive payments this year. We don't know exactly how much, but we know that you did meet the threshold to receive. We look at the data at the high level, and then we dig into the data at the practice level. So I want to show you trends for the entire ACO. If you look at how benchmarks are calculated, Medicare compares you to 2016 and 17. You can see that costs have been increasing. That's true for Doctors ACO in your benchmark. That's true for all ACOs across the country. But look what you've been able to do. In 2020, you've been able to reduce costs each quarter. That's what translates into shared savings. This is the target that you have to hit. And as you can see, independent physicians prevail. You have been successful. Most of the cost is in hospitalizations. So some physicians, they say, hey, if I'm seeing the patient more often, how am I saving? And the answer is primary care services keep your patients healthy. They manage chronic disease, and they keep the patient out of the big expense, which is the hospital. So that's why we encourage you to use Care Tracker. That's why we encourage you to use TCM, because when you spend more money in your office, you benefit, but also the patient benefits by less hospitalization. The gateway to the hospital, SNF home health, it's the emergency room. You can see how you've been able to effectively reduce unnecessary ER visits. So the formula that you're using is working. So keep it up, do higher volume. If you're able to see your high-risk patients more often, if you're able to see a higher quantity of wellness visits, we only expect this trend to continue. Not everything's perfect, right? So home health for doctors ACO is increasing. If you look closely at these numbers, they're not quite as big as the admissions. So you would rather reduce admissions and have home health go up. There could be a trend with a lack of nursing home and patients being encouraged to go home. This could be caused by this, but this will be something we definitely work on for next meeting. Anything where the costs go up, we have to fix it by the next meeting. So you'll get more information on this. So we always look at the data. By the way, your data is public information. So if you have the right people, they can always see your performance. That's why we want to share this with you. That's why we want to be transparent, so you can make sure that you look really, really great on paper. We know you're the best physician in person. We know you're the best physician with your training, but it's our job to help that great physician to look good on paper, because this is what Medicare looks at. This is what the commercial payers look at. And this is what the patients are going to be able to see. So we want to help you with these metrics. So these are our distinguished Columbus, Georgia practices. And I want to remind everyone, if you want to increase your payment, okay, there's only a few metrics you have to look at. So if your payment's too small and you say, hey, I did everything the ACO asked of me, you got to look at these metrics, okay? Because going to meetings, it doesn't increase your payment. Increasing the quality score does not increase your payment that much, but increasing the number of patients in your panel, it does increase your payment. Reducing the per member per month cost, that increases your payment. So we're going to reiterate that over and over to make sure there's no confusion. If you want to do well in the ACO, you want to do well in those two metrics. If you look at the practices in Columbus, you have some really great savers. Please keep it up. Those of you that are not saving, there's plenty of great metrics on here, but you can see that every single practice is performing better than the region. So the way that Medicare makes the payment is they want you to improve. 50% of the benchmark or your performance and cost is based on improvement. And then 50% is based on your comparison to the region. You're all independent practitioners. You can expect your lower costs than your hospital counterparts, and that shows in the data. But if you want to optimize your payment, you want to improve, and you want to be better than the region. You are now receiving alerts through the app. Most of the alerts for Columbus, Georgia come from Piedmont Hospital. For years, we would hear from physicians, I can't manage readmissions because I don't know when my patients go to the hospital. So the ACO pays a fee each month for you to get all alerts of your patients being admitted to Piedmont. Please work those. Please get those patients in. You can see some doctors are still having trouble getting the patients in for transitional care management. They're having trouble doing post-discharge visits. The post-discharge visit, all it is an office visit within 14 days. But you can see that the physicians in Columbus that are excelling at seeing the patient post-discharge, they have the lowest readmissions. That's the whole goal. If you could get a PCP to see the patient post-discharge, that's how you manage readmissions. So please use the app. Some of you are not, but please use the app. Please make sure you're scheduling patients post-discharge, and you too will be able to manage readmissions. Again, we don't want to have any confusion. It seems around payment time, that's when the biggest confusion occurs, right? My check is a little bit too small and that other doctor is way too excited. So we need to talk about the source of the payment. If you work 35% of the time on your assignment, you'll be very happy with your payment. You want to get average patients, you want to grow your panel, and you want to watch out for nursing home. You want to watch out for taking additional ER call, because that's the type of assignment that can really hurt your payment. You want to work on cost savings, ER frequent flyers, high risk patients. This is what really contributes to reducing your PMPM. But you want to be well-rounded too. You want to pay attention to quality. You want to pay attention to the preventative measures. You want to pay attention to managing the hemoglobin A1C and hypertension, right? That contributes to the overall package. But if you're interested with the payment, you got to look at the first two items on here. We can't go over everything at one meeting, so I want to give you just a quick recap of what we're going to talk about at the next meeting. So home health is going up at the next meeting, and everyone's invited. We're going to talk about how PCPs can manage home health. MRA is a component of your payment, so we're going to make sure we talk about MRA at the next meeting. And as always, you can always expect this from Doctors ACO. We will always share how well you're doing as PCPs, and we're going to share individual opportunities to improve. So now we have local leadership. So I'm going to ask Dr. Raj Alapan to speak with us. We have a very distinguished guest. Thank you. Can you please share how we can do better here in Columbus, Georgia? It's a big room. It's a long walk. Thank you, Chief.
Thank you, David. Actually, I've been put on the spot to talk about ACO. One of the reasons I feel that it would be right to be here would be that we had an ACO before in Columbus, and that ACO existed for 3 years. I'm just comparing and contrasting where we are before and where we are today. And it was kind of an experimental stage of the ACO, the previous one. And during the process of our journey, I learned a lot and instrumental in getting them together in some form or other in a little way. And what happened? We ended up actually doing fairly a phenomenal job. And when it comes to the time when we have to achieve the benchmark, we actually missed it by 0.2% for the first year. So we did not turn the corner. Come second year, we did the same thing. And I think I can give the number, it was actually close to 0.2 or 0.1%. And we did not succeed. And the third year, we did make some improvement, and there was some payment because we did cross the bar. It wasn't that lucrative as we would all like to have one. Comparing that to where we are today with the Doctors ACO, we have now come to a state where we not only are participating, this is a shared saving program, and there is also a risk involved if you don't meet the benchmark. But having said that, for this year gone past, we did meet the benchmark. We did come on the upper hand, and we all saw some benefits of our ACO. So if I have to put it in a very short way of expressing, Doctors ACO is an ACO which seems to be doing the right things. It's doing everything what we all want to be, and not disclosing the figures. Everybody was happy in getting the returns for having been in the ACO. From my standpoint, I'm a specialist. I'm a nephrologist. I will be the least wanted person in any ACO, because the kind of a patient we have are the sickest of the sickest, and the ones who actually will be draining your finances and resources. Nobody will want to be the physicians for this kind of patients. Having said that, we have already have a sound track behind our patient group. we have actually made a big impact in Columbus, especially our renal practice, where the hospitalization was drastically reduced, even in the previous ACO, by way of the access centers and also giving them a proper care at the appropriate time. And you will find these patients were not actually going back for readmission rates. Shortly, to discuss what is the specialist role in being in doctor's ACO. The way I look at it, we as a specialists, we come with a different angle we come into this ACO. First, you are joining a group of body who are aiming to set standards and have some quality measures. So being part of that for us becomes actually a plus to be among a group where they are going to establish a certain quality care. Number two, Medicare requires you to have the MIPS and MACRA. Now, when you are in an ACO, which is already getting the benchmarks, you're already covered by the ACO. So you will be actually don't have to reinvent the wheel of how to go about doing this. Thirdly, the quality care which we are not only providing is being provided by the primary care physicians, we are also now, by being part of it, are making sure that we also follow the same line. We toe the line and we also have to practice the quality care. Not that we are not. I can boast that Columbus does practice very quality care, but we still strive for the higher bar. We set the standards high and we work around that. Then the next one would be, we are doing this particular practice with prudence and care. But the most important thing is that we have a body of physicians who are around us who we can cross-refer, get necessary patients, referrals, easy accessibility, and we have a certain level of interactions which is much more easier if you are in one group in where we are. Then there's also a possibility, as and when it opens up, there's an investment part of it, which if you're allowed to invest, there are some returns which you can think about it. Now, the Columbus market is very unique. We are actually isolated from Atlanta, 80 miles away. To get physicians into this community itself is difficult. But when they come, they stay. So everyone knows everybody else. So to be part of this organization becomes much more easier, and we can bring them in. As an independent physician, it is very important to make sure that we stay independent. We are not actually being walloped. We are not being eaten up by the big kahunas, as we call, the bigger ones. In Columbus, we have two big bodies which are now encroached, and they are here. There is Piedmont Group, and there is the Emory Group. So if you align with them, you are one among the hundreds. Whereas if you're going to be in a situation where, like ACO, like the doctor's ACO, you get unique recognitions and there are returns to that. So what we are trying to establish here is that whatever we are trying to do here in Columbus is possible that this can be applicable out there for you all, wherever you are, in whichever part of America. Being part of the doctor's ACO, I think, will show a better, prosperous future, and your returns are going to be actually, we can be, we are the proof to that this returns will be growing, and you will see that by staying here for the longest haul, you're going to do much better. With that, I will close my section, and if there's any questions with regard to specialist participation, would be open for a discussion. Thank you, sir.
Hello, my name is Brian Edwards. I am the Atlanta consultant provider. And on Sunday, we finished our third quarter data for Care Tracker. And Care Tracker is a wonderful tool that we use in all of our offices that helps optimize the paper reports that we were bringing in. So your annual wellness visits, your ER frequent flyers, your drop patient lists, those reports are all optimized, and you are able as providers to check and see if the work is actually being done in your clinic. Sometimes you think it's being done, but it's not really being done. So there's a way to check that and make sure that work is being done efficiently and as optimally as possible. Just today, Dr. Agarwal allowed this wonderful news that our Q4 data that was loaded yesterday will need to be completed by May 21st. And once you complete that, you will earn $500. For Q3, out of all of our practices, we had 32 practices that acted on 100% of their Care Tracker actions. That's wonderful. 100% of our Columbus practices completed their entire panel. Please, everybody needs a good job. Each and every practice gets $500. We had one practice that had 90 to 90%, two that had 70 to 89, two that had 40 to 69, and three that fell just a little bit short. And Rochelle and I are here to help you with that. So we will definitely come up with a plan to get you there for next quarter. Here are our $500 winners. Those checks will be going out shortly. Again, 100% of our Columbus practices made it. A number of our Athens practices made it. A number of our Ohio practices made it. And a large number of our Atlanta practices made it. Here's a breakdown of some of the practices that need some work. But again, we're all in this together. That's what Rochelle and I are here, is for your success. Your reports break down into 4 different categories. High cost, high risk patients. These are the patients who need the most attention, right? These are your frail patients. These are those patients who need a little extra care. ED frequent flyers, or EDFF, are patients who are using the emergency room for oftentimes their primary care.
What is blue sky that people who don't understand the ACO?
Sure. If you don't know what blue sky is, call us. Call Rochelle, call myself. We will sit down with you and give you a tutorial on what blue sky is and how it can help benefit you in not only the long term, but in the short term. You can capture your patients who are misusing the emergency room. You can capture those patients who are dropping through the cracks because they've had missed appointments. Maybe they don't have transportation, right? Maybe they're bed-bound mute patients who have trouble getting around. These are patients that we need to reach. Also, your patients who have your annual wellness visits. These are the ways that you can track those patients and notify your staff, or your staff can notify you that, hey, this patient is coming in for the annual wellness visit. This is not additional work. This is work you were already doing. This is just optimizing that work. Think of this as sales leads, right? If somebody came in and gave you a bunch of sales leads, this is money that's going out the door. And what we're trying to do is capture that money and help those patients who really need the help. As I said, as doctors, as the 10 owners of practice, you can always check in Care Tracker and see if your staff, if your front desk, if your office team, if your care coordinator is doing the work that you assigned them. We can show you how to do that. We can show you that they completed 21 actions. Right? You can do it each day. You can do it each week. You can do it each month. You can always see how much work is actually being done in Care Tracker. If you did all your actions in Care Tracker, Medicare says, you know what, these are patients that need some extra help. We normally see them 4 times a week. We recommend you seeing them 7 times a year, right? Instead of 4 times a year, see them 7 times a year. You saw your patients an additional 3 times, you're looking at an extra $41,000. It's a lot of money for work that you're already doing, work that you're doing for patients who really need the help. Your annual wellness current performance, you have 107 assignments. If you got all your stuff done, You're looking at $45,000 on top of what you're getting for shared savings. So this is a great opportunity to increase your shared savings, but also serve the patient population that you want to serve, that needs your help in a great way. If you have any questions about Blue Sky, about Care Tracker, please let Rochelle and I know. We will be there with bells on, ready to help you and your team learn about this wonderful tool.
Thank you, Brian. All right, so I am Rochelle Gordon. I am the Athens and Columbus consultant for Doctors ACO. First and foremost, I would like to congratulate our Columbus practices who are here with us tonight, again on 100% completion for Care Tracker. I'd like to give a round of applause to all of those providers. I'd also like to congratulate all of our providers for doing a wonderful job last year. Given that we encountered a pandemic, our providers adapted and overcame a lot of interesting, or at least to say interesting roadblocks. And so again, congrats on that and good job. Tonight, I want to touch base a little bit on our Blue Sky app. And so what that is, of course, is it's just a benefit to our Care Tracker app. And it can be downloaded on your cell phone. The office managers and the providers in each clinic can have this app on their phone. And of course, with this is kind of the workflow. So it does mirror our Care Tracker that you utilize every day in your office on your desktop. And so on the phone, of course, it's going to show you if a patient has been either admitted or discharged from the hospital. You can simply go into the app and then you can complete the action item that would be appropriate to the patient. Also with this, the providers, of course, can contact the attending, and they can kind of work through the process with the provider or with the hospital. And especially as it comes time for the discharge, then we can ensure that that patient is actually getting to be seen back in the office by the PCP. So it's quite simple to download the app if you don't have it on your phone. Brian and myself can help you download it today. For our iPhone users, you just go to your app store and you simply type in SuperDoc ACO. And then of course it is the same for our Android users as well. Actually, really quickly, I'll go back. So just for the login for the app as well, it is the same email and password that you have for your Care Tracker that you use on your desktop. And so, of course, you would use that same login for the app. Also, the benefit to the app is it assists with our TCM. And so, of course, if we're needing to help capture those TCM appointments, that's a great benefit to utilizing our the Blue Sky app. All of our providers and their staff are aware of what TCM is. Of course, it is a transitional care management. And what that is it's discharges from, mainly a hospital setting, but of course it can go from discharges from long-term care facilities, our SNF. But again, with the TCM, within 2 days or business days of contacting the patient should then be seen within 7 days back into the office. The benefit or the purpose of that, of course, is to ensure that the patient, that the meds are reconciled from the discharge, and then as well as looking at the care plan that the hospitalist may have provided for the patient and ensuring that, that is appropriate. Sometimes they catch certain diagnoses that maybe the PCP was not aware of. And so, of course, with this particular appointment, it's a great way for the patient to keep receiving care, but then also, the benefit of it is to prevent readmissions. And so when we're billing our TCM, there's 2 particular codes that you'll be able to use. Of course, if you are using the higher complexity code, which is our 99496, the patient does have to have a more complex diagnosis. It also requires a face-to-face visit. Now, that doesn't necessarily mean that the face-to-face visit has to occur in office. We can still conduct the TCM visits via telehealth. So again, just a quick reminder is that the patient come discharged. So once it notifies you on the app, you have to contact the patient within 2 business days. And then of course it is good recommended practice to get them in within 7 days in order for you to receive the max amount for the reimbursement for these codes. So is TCM reportable for new and established patients? It is. So of course, if you have a patient, maybe that's frequenting the ED a little bit, of course, TCM cannot be used for ED discharges though. It is for an inpatient discharge status. Another thing is that, again, it does not have to be necessarily face-to-face in office, but you can conduct these visits via telehealth. So of course, some of the compelling reasons to do TCM is that these do help count towards assignment. And so of course, when we are looking at our Medicare panel, these particular visits do help with assignment of our Medicare patients. It also helps with 50% of discharge results or 50% of the discharge results from these particular diagnoses come from these particular patient groups. And so of course, as you know, especially if you are a specialist, so for example, if you're a cardiologist, you know that a lot of your patients, their readmission rates are going to be higher than your average PCP patients. But again, with the TCM, this does help capture this transitional care management process for the patient, but then also for our PCP patients as well. The immediate practice revenue is anywhere from $200 to $273 per patient. And then of course, every admission costs the ACO roughly $3,700. And so keeping those patients from readmitting back into the hospital, of course, ends up, benefiting our providers and then also the patient in the long run. One bonus to being able to capture these TCM visits is the utilization of our support center. And so with that, of course, our support center monitors the patients on Care Tracker just as much as our offices do. And so when they notice that a patient is either getting ready to be discharged or has been discharged, our support center can contact that patient within the 2 business days and then of course get them scheduled for you. Our support center not only helps capture TCM, but they also help schedule our Medicare annual wellness visits. They help schedule routine follow-up visits. And so it's a great benefit and it's a great offer that we have to our ACO members. For example, this is pulling from one of our, this is data that has actually been provided from one of our ACO practices. So there was a 37% increase in completed annual wellness visits between 2019 and 2020, as you can see in this practice. So the significant increase was completed of the annual wellness visits. But then of course, with that, it also helped decrease the PMPM. And one of the things, of course, with decrease in the PMPM is monitoring those expenses. And so if our support center notices maybe that the patient has been frequenting the ED, they can contact the care coordinator in the practice and they can suggest, there's multiple programs. One of them, of course, is our Thursday Touch program, ensuring that some of these ED frequent flyers are being contacted before the weekend to ensure that, over the weekend for call purposes, they're able to get a hold of their provider. And then of course, I have another example as well, just showing you that our support center really is a great benefit to our ACO practices. This one shows almost a 50% increase in completed annual wellness visits over the year, as well as almost $70 decrease in the PMPM. And this was due to inserting the support center into this practice in 2020. It paused. Thank you. So there's a few little requirements that we require from our practices in order to utilize our support center. Of course, it is to be able to access their EHR remotely. Of course, we need a contact person. So for example, that care coordinator in your practice. What this does is it helps our support center be able to get in contact with them regarding the first official startup, but then of course, as going forward, when we discuss patients, but having that person of contact really helps keep the flow of everything going smoothly. Some of the other things then, once our support center is actually in the practice, then of course they coordinate with that care coordinator, and they're able to look at the actual schedule. And so for example, if you only have a nurse practitioner in your office for 3 days on Monday, Wednesday, Friday, our support staff then knows that they can only schedule Monday, Wednesday, Friday, those particular patients, even at particular times. And so they are a great benefit to all of our ACO practices. And, I would love to get all of our Columbus practices signed up with our support center before the end of the night. The next topic that I would like to discuss, of course, is the outreach program. Currently, we do not have an outreach program in Columbus, but we are actively looking to include an outreach provider in the area. Just to touch base quickly on our outreach program, what it is it's utilizing home visits to help decrease admission and readmission rates. And generally speaking, when we're referring patients, most of these patients are high-risk patients, and they're referred to our outreach program from their actual PCP. Now, of course, one of the main concerns that we get when we mention this program to our providers is, well, will I lose this patient? And of course not. These patients are still yours. You still act as the PCP to these patients, but we kind of look at our outreach providers as like a mobile provider or even a specialist per se. And so they are able to then go in home to these particular patients, and they treat their necessary diagnoses in home. This has helped greatly decrease ED visits, as well as some of those patients, I don't really like to term them non-compliant, but maybe they just, especially during a pandemic, they didn't have much intentions of leaving their home. And so by having a provider be able to come in home to them, it's a great benefit to them. And then, of course, our outreach providers are also able to conduct TCM. And so they're able to see most of our patients within 72 hours of discharge, which of course, helps decrease that readmission rate. With our outreach program, our outreach providers, we work very closely with them. And what I mean by that is that our support representatives maintain an active ongoing spreadsheet of all of our current patients that are enrolled in outreach. And so, for example, when the provider comes to myself or Brian, the other consultant, with a potential referral, we then send that referral directly to our support center. Our support center then, if they have remote access to the practices, they are then able to compile all the necessary documents. They then send that information directly to the outreach provider. The outreach provider notes following every single visit. So of course, when they do, or they are able to come back into the office, you're aware of what was being conducted, or maybe they had a med change. So again, that process is kept very clean and concise. Whoops. So again, thank you. I would like to now bring Dr. Agarwal down to speak a little bit more.
This is for here, as well as people watching from outside on the Zoom, and people who don't know anything about Doctor's ACO. We want to show you this. All these tools we show you, they were all free. So if you're part of the ACO, are we okay? All right. So you're part of the ACO, this care tracker. You got access to your app from hospital, and the support center is all free. Now, if you don't use it, if you don't use it to improve your practice, to make your practice high quality, low cost, that's up to you. So what happened? I want to bring the topic of independent physician. We are independent physicians and they are shining physicians all over the United States. One of them is Dr. Vinod Sanchetti. So Vinod, take it from here. Tell us about you.
Yeah, thank you, Dr. Agarwal,
You okay with
asking me
Vinod?
to join your meeting. Can
So-
everybody hear me?
So Vinod is basically a independent physician, primary care physician, and leader in local community, and has created a New Jersey ACO, which has significant improvement in care. Now they are high quality and low cost physicians, and moving towards creating a Medicare Advantage plan in that area, including other physician, independent physician in their practice. I just feel like he's one of the great leader, independent physician. He is also very social locally, and I really want him to talk to us about it. Vinod, are you on?
Yes, yes, I am on. Thank you, Sudhir, and all the members at Doctor's ACO. We just want to share our success story at New Jersey. We started our ACO in 2014. So after first 3 years, we were not able to get shared saving. And 2018, 19, and 20, we have our management company from Palm Beach ACO with Dr. Bansal. And finally, we cracked the ice on 2019. We received a shared saving of $5.1 million, which was distributed based on patient number to all the participants. And I think biggest practice which received the dollar amount was close to 300,000, so, and internal medicine, our most of our practices are internal medicine, except I would say 9% of the practices are internal medicine and nephrology, internal medicine, cardiology, but they are far and few 3 practices only, So we are on the right track for this year also. In 2020, I think we expect shared saving close to 12 or 13 million. Final reconciliation will be done in next couple of months, but we are on the right track going forward now. So we are a risk-based ACO, just like Doctor's ACO, and we are in New Jersey. We have physicians all the way from North Jersey to South Jersey, as well as some of practices now we taken in 2020 are from New York. So we're trying to expand beyond New Jersey perimeter now, and going to New York as well as Connecticut. So, and we have approximately 10,000 patients on Medicare, and at the same time, we do have a managed Medicare contract with Blue Cross Blue Shield. And we have we control 10,000 lives from Blue Cross Blue Shield in New Jersey, which include all the product of Blue Cross Blue Shield except Medicaid product. So we did receive shared saving from Blue Cross Blue Shield on 2018 also. And beside that, we do get money on every quarter from Blue Cross Blue Shield.
So he runs the practice, he runs the ACO, and now what else you doing? Tell us about that. He's
I'm involved in a lot of social organization here, so.
He's also going for API secretary position. And tell us what you want to be elected. What are you going to do?
I'm going to just, I'm trying to get the secretary position at AAPI and change certain things in our national API, so in leadership roles.
So thank you, Vinod. Vinod is a leader in New Jersey, and we want leader like this all over the United States. So if anybody missing something, help something, please call us, call Vinod, call Raj, call one of our independent physician. We can help. We can help bring the high quality care in your area. So what we're gonna do, thank you, Vinod. We're gonna open for questions. So Dr. Alapan, come on up here, and Vinod and David, and see if we have any question on the chat, and we can answer those questions. Sure. Go ahead.
So when the pandemic hit in March of 2020, we noticed that many of the PCP practices closed. They did not know what to do. There was a lot of concerns from staff. So we immediately mobilized to help our physicians, and we created a comprehensive telehealth guide. So you have enough challenges with staff and contacting your patients. So we made the billing very straightforward. So those attendees to the call, you can download the comprehensive telehealth billing guide. It says exactly what's required to bill the various codes, whether they're phone only, TCM, telehealth, and then also exactly how to do the documentation. So please download that. I actually heard that Dr. Agarwal, his ACO did the #1 highest volume in telehealth in the country. So I was invited to speak on your behalf. Thank you. That was really great. Yes. It was care journey. It was interesting. And I just wanted to share a little bit of history. Is you see 3 classmates, Dr. Agarwal, Dr. Sanchetti, and Dr. Bansal, and they're all promoting each other across the country with high quality independent physician care. So that's kind of a little bit of the connection of multiple ACOs, a little bit of friendly competition, but all very, very successful. Brian, any questions? We did get a couple questions. So please download the telehealth guide if you're interested. There's been 2021 E&M code changes. You can download those as well. So, you know, maybe you were not aware of all of the exact details of the 2021 changes. You can download this. There's also a consulting company on there. So if you have easy questions, please ask your ACO team. But if you have an advanced question, maybe something that takes a whole afternoon, or you'd like to educate your staff to make sure that they're very, very thoroughly trained, you do get a discount if you mention Dr. Agarwal's name and Doctor's ACO, and that is a comprehensive billing and collections company called Acevedo Consulting. We were asked if, this is a very hard question. We were asked if you do a wellness visit by telehealth, does it need vitals? And we've asked Medicare several times and they won't say no. So what they want you to have is patient reported vitals. So hopefully the patient has blood pressure cuff and they report it. But there is an opinion, they just didn't put it in writing, that if you say patient unable to do it due to public health emergency and you document it, there is definitely word for Medicare that they're going to be doing limited audits. So you can read that, that's out there. And that is the opinion of some. It's just that there's no documentation. So we urge you when you're doing the wellness visits to try to do the vitals, but there is some opinion out there that if you document correctly that you attempted and did not do it, you may still be paid.
Can I ask you a question? Can you go over the SuperDoc ACO app with reference to that? How does the specialist can use it, in what way?
Absolutely. So we load, particularly the internal medicine trained physicians, so endocrinology, nephrology, cardiology. So you'll see when you are the primary care physician, when they're not seeing another primary, your name as well as the patient's name are submitted. So here locally, if your patient goes to Piedmont, you will be notified. You, Dr. Agarwal, you, Dr. Baliga, you, Dr. Alapan, you do have some patients where you're the primary, and then you as specialists, you'd have to manage that patient post-discharge to reduce the readmission. But generally, the PCPs have their assigned patients, and that's where you get the alerts. And then it's the Piedmont and other hospitals. You'll notice that you get many, but not all of the alerts when your patients go to the hospital.
So the alerts are going to come through the app.
That's correct.
So how do they know about this patient belong to Dr. Alapan or Dr. Baliga? We give them list of the ACO members, is that right?
That's right. So Medicare assigns the patients based on the doctors who are seeing them. And then #1 is the priority goes to the PCP, but if the patient does not have a PCP, then it goes to the specialist that sees them the most.
So
and you can get your panel at any time from the ACO.
If Dr. Alapan patient get admitted to Piedmont,
Yep.
Does he get ping on his app?
He does, but you may need to meet with Rochelle, get some training.
Can
make
you
sure the
imagine that?
staff-
Can you imagine that? You get a ping on your app that your patient got.
There's some information or notification. We should be able to address it in some way, but if we are not primary care, then we can address it to their respective primary care docs.
That's right.
Am I right?
That's right. Perfect.
So the specialist don't get ping. The primary care doctor get the ping.
So when there is no primary, the specialist will be pinged.
Then we are to pay.
Okay.
The next question would be, do you have like a checklist what are the things the specialists have to do, because since we don't do it all the time, somebody will be there to help in coordinating this care in that specific patients who don't have the primary care?
Yes,
Can we
it's,
find a primary care for them?
yes. So the checklist is pretty basic. It says contact the attending. It says share medical records. It says contact the family or caregiver, and then make sure you have a primary care visit post-discharge. But Dr. Alapin is an expert. You know, you would get that patient to a PCP. You would give your consultant opinion. And then the key is that you got to manage the readmission. So readmission is the highest, most regarded quality measure and the one that affects your payment the most. So the more that we can work on reducing readmissions, the better you'll be.
Do you
So-
have a system where if a patient is sick, I know they all call us through our answering service. Is there a way that we can call somebody related to ACO who can be the middle person and then direct the call to the respective physician who can take care of it rather than going to the ER?
Yes.
Do you have that system already in place?
So hopefully all of you here are going to enroll in the support center. So we have 2 full-time employees, and their job, and they actually call about 200 patients a week. And you are not benefiting from that right now. But if you're able to utilize them, they have access to physician EMRs, and there's no point in between. They schedule with another physician, a primary in the area, and then they make sure that they're being seen. But other doctors are benefiting from this. Their shared savings checks are going up. You know, they may not have had the staff, but they use the ACO staff. But yes, absolutely, that's something that they can do.
So by doing this, you think our Columbus physicians are going to bump up in their returns?
They're doing well, but I think if you add more staff, high quality, more physician visits with the PCP, absolutely, yes, sir.
So David, let me ask you a question. For other people who are independent physician, but they are not in ACO or not ACO, which is not giving them money. So what they should do, what they're missing out? Can you summarize that in about a minute?
So if you're in an ACO, you have the incentive to perform. If you're not in an ACO, you may already be doing a very good job and Medicare is not paying you for it. The second thing is you may have to spend a lot of time doing MIPS. So, you know, you have to have a registry, you have to have staff in your office. Usually they estimate it's about $25,000 a year in labor to do MIPS. But if you're in an ACO, the labor goes down a lot because you still have to submit quality, but it's spread out over 100 physicians. So you have much less work. That's another benefit.
Tell us about that 5% every year for full.
So if you are in a risk ACO, not only do you have much less work on MIPS, but you automatically get 5% added to your fee-for-service collection. So that's called the APM bonus. So any physician that's in an ACO that takes downside risk,
that
they get
including
5%.
specialists, right?
So that's added to your consult codes. That's added to any ancillaries in your office. That's added to testing that you perform. You get 5% more billing on everything you charge to Medicare. And the other thing is that you get to work together collegially with your peers. So, you know, hopefully today, other physicians share how they're billing wellness visits with telehealth. You know, hopefully they share insights on how Piedmont can do a better job, right? So the benefit is you get to work together with other physicians to be higher performing. You get to benefit from the ACO resources to help your practice. But, you know, our physicians in Florida, they commonly say, I don't know if I could be an independent physician without the ACO. And that's a big compliment, but they benefit a lot from the ACO camaraderie and ACO structure.
When and how do you get that 5%?
Can use the ACO to benefit our physicians here? And have you all gone through one by one so that you can make your ACO better and the physicians' returns better?
On paper, these Columbus physicians look very high quality. You can tell they're independent physicians. You can tell they care about their patients, and you can tell that they're better than their hospital peers. Every physician has room for improvement. And, you know, maybe it's on the first page, maybe it's on the 5th page, but there's always room for improvement. You often don't know where your patients are going. You often have patients that are non-compliant, and through the data, you can understand where you can improve and ways you can get more ACO payment.
So David, let me ask you another question. What is the next step after a successful ACO? With group of physicians get together, what they can do next?
So in Florida, we've had a successful ACO since 2013. So it's a little early for Columbus, but maybe next year. But in Palm Beach ACO, the physicians organized and they started their own Medicare Advantage plan. So they don't work for the Medicare Advantage plan. The Medicare Advantage plan works for them. So they have an insurance company. They have a partner that's an expert in insurance. And then when they enroll patients, it doesn't help out some big corporation. It helps them out. And on paper, it looks like that, they have a way to make more income, but if that entity ever sells, they've built tremendous wealth for themselves. A lot of these HMO, Medicare Advantage plans, they sell for hundreds of millions of dollars in just after a few years. So that would be the ultra high milestone, is you have a great ACO for several years, and then you can actually do something really big, like have your own insurance company.
So
I did
this
get a
is-
couple questions.
this
Yes,
is-
sir.
Yeah, let me ask you this question.
The kidney care. There's a new initiative by Medicare for kidney care,
Yes, sir.
which can also be brought under the ACO wing if you want to spearhead them. For all those physicians who are on the nephrology side, there is a new initiative by Medicare, what is called as kidney care. And if we are able to actually bring in the necessary know-hows, how to actually do it's actually like a shared plan where you can actually, it's a shared saving plan. So in that situation, if you can get the ACO to do the spade work and bring it to the ACO members, that'd be a good thing too. So I did sound that 2 days ago for you. Any feedback on that?
I'm not as advanced as you, please.
Okay. No, we are still in the rudimentary stage, and it is being actually called in. If any of the panelists out there who are actually connected to this afternoon meeting want to throw some light on it, on the kidney care and the Medicare Advantage plan.
So it's open to anybody who can unmute themselves. Please put your light into it. Kidney care in Medicare patient. Any suggestion or any idea, any knowledge?
If anyone would like to unmute or raise your hand to speak, we can all hear you here.
So David, there's a question. There's a urologist in Melbourne, Florida. How can he join ACO?
Urology?
Yeah, urology specialist.
So send your contact information. A gentleman will share an email address. So if you would like copies of the slides, please email me and we'll provide you a copy. But if you're interested in joining an ACO, Dr. Agarwal has classmates in Florida, in west side of Florida as well. And we're interested in high quality PCPs and high quality specialists, including urology. So there is an ACO likely close by that you can join.
Great.
There was an additional question here. How does the hospital know our patients? So there are multiple HIEs. There's one that we use in Georgia, so Health Information Exchange, and there's one that we use in Ohio. And what happens is if we give a list of all of the patients that are in the ACO, and they use technology, and as soon as the patient goes to the hospital, it sends an alert through their HIE that we relay to you from the app. So we give a list, and if there's any match to a patient that gets admitted or discharged, the hospital lets you know. And the Piedmont network is the biggest network. So you'll notice that probably a little bit more often than your admissions at St. Francis. The 5% bonus is paid directly to your practice. So, each year you're going to perform in the ACO, you're going to get an ACO payment, but you're also going to get a payment through the 5% APM. It's going to happen for the first time. It's going to be this year. It'll happen in October-ish as it comes around the fall, but you'll get a check directly to your practice for 5% of your previous year Medicare billing. So if you build $100,000, it'll be $5,000. If you build $500,000, it'll be $25,000. So that'll happen in around October of this year. And then if you're new to the ACO for 2020, then it'll be in 2022. So it takes them 2 years to process the paperwork. It's kind of like PQRS and EHR was in previous years. So 2 years from the year of the ACO.
So it's been pleasure to be in Columbus, Dr. Alapan, and thank you for providing leadership. We really want this Columbus to become leader invited all the doctors around this area.
I thought they're already leaders here. By your indicators, they all got the best.
That's,
They have.
Well, we all have to improve.
but as a specialist, I believe that you need to protect your primary care physician from a hospital. And that one way to protect them is to bring them in the ACO.
The issue is that they've already been engulfed by the bigger party.
Yeah.
So that's why.
Well, thank you all. We had a great time today. I hope you had a great time. And thank you, David. Thank you, Dr. Alapan. Thank you, everybody
Dr.
else,
Agarwal.
Don and great Brian and Rochelle. And thank you all the attendees to join meeting. This is Columbus, Georgia. Thank you.
Thank you, audio video. Great job. Well done.